Good morning from New York, or anytime you may be around the world watching this live webcast. This is a structural heart disease case, aortic valve replacement via transcatheter methods today. Let me remind you that you can always send us a comment or a question at the website, at the, I should say, email, info@structuralheartlivecases.org. And you can see this case, if you miss it, or any other case in the archives portion of the website you're watching. Let me remind you, tomorrow the structural heart and coronary and vascular heart symposium will be live here at Mount Sinai. I'm going to give more details in the end of the webcast. So without further delay, let's go and meet Dr. Sharma and the team in the catheterization laboratories.
All right, good morning, and everybody should be, we are sorry for a little delay to our audience, but we have our case number 11 on the structural heart webcast, and clearly with a team, so we can take up everyone on the picture with Dr. Alan Stewart on my right side, Dr. Jason Kovacic in the back, and Dr. Keeney will be joining along with fellow Assad. On the echo, we have Dr. Chowdhury, and anesthesia, Dr. Khan, and rest of my cath lab staff here. So since we are delayed, we just accelerate a little process. We'll have more time of discussion later part. And this patient, if we can get to our slides, these are our supporters. Next. It's a, as you can see here, 79-year-old female with classical exertional dyspnea and fatigue, has a severe AS, good medication, a high gradient, and we actually ask Dr. Chowdhury to just show from the echo point of view.
So we can see here on the we have a pediatric transesophageal probe, and we can see on the short axis there's limited excursion of the aortic valve leaflets with turbulence on the forward flow and a touch of AI. And then we move on to the long axis. We can see that the leaflet opening is restricted and there is a trivial aortic regurgitation.
So you're using pediatric probe because the patient's under moderate sedation, is that right?
That's right. It's more comfortable for the patient, although the image quality is not as optimal, but yes.
But at the same time, many of these cases that we are doing with a transthoracic echo also. I mean, clearly in the questionable case where there is some septal hypertrophy and some valve issues, maybe you want to get more precise, but otherwise transthoracic echoes with the echocardiographer wearing the special lead glove. Otherwise, we'll develop issues for the constant radiation that we have done cases with the transthoracic guidance also. Okay, now continue, next slide.
And then this is a short axis transgastric view in the stomach, and we can see that the LV is moderately impaired. And then if we look at the mitral valve here, there's mild mitral regurgitation.
Perfect. Okay, with that note, let's go back to our patient with a mild pulmonary hypertension, non-obstructive CAD with severe AS and mild AI, and we know that patient has a known non-ischemic cardiomyopathy and has a AICD placed in 2010. EF is around 30 to 35%, as just mentioned. Next. Then of course we'll go to individual of our CT angiography, but vessel size are good, more than 0.6 centimeter, and STS risk is 3.08 with the Euroscore mortality of 6.7. Patient had a heart team discussion. Dr. Alan Stewart, our surgeon, saw the patient also and labeled as a high risk because patient has a breast CA, radiation, has a mastectomy, and of course with the cardiomyopathy. Therefore our plan is today with evolute our CoreValve 29 millimeter under conscious sedation and with a percutaneous femoral access, which JK, Dr. Kovacic will just guide us through.
Good. Next slide, please. So the echo we've seen. Yeah. Next slide. Next. So just to take you through the CT measurement, the assessment for the case, here we are at the annular plane. You can see the minimum and the maximum diameter is about 26.9, 22.1, giving us a mean of 24.5. There's just one spot of calcification up at about 1:32 o'clock in the annulus there you can see, so not much calcium, and we can comfortably post-dilate this with a 24 millimeter balloon if we need to. Perimeter is 77 millimeters, and the annular angle is about 51 degrees. So it's a little bit, just tending a little bit horizontal, but not badly. Next slide, please. Here you can see the SOV measurements. Sinus of Valsalva is about 31, so fairly generous. The STJ height is 20 millimeters, again generous. ascending aorta 29 millimeters across. The coronary ostia height, you can see the left main is very high, 18 millimeters. We only get worried if it's 12 millimeters and below. So we've got no concern today about coronary ostial occlusion. Next slide. You can see here the access in 3D. A little bit tortuous on the left side, but not a lot of calcification. Next slide. Here you can see again the vessels in cross section, about 8 millimeters in the common iliacs. Next slide. So these are the measurements for our case today. Comfortably a 29 millimeter evolute valve by all measurements. Next. The summary of the case I think we've been through already. High risk. Just go to the angios now and I'll take you through what we've done so far.
Yeah, before we go on to the angio, let's ask Alan. Now these cases now has become routine, right, Alan? From your practice point of view also, if somebody comes even for surgical valve replacement, you feel like intermediate to high risk, preferring TAVR procedure?
I do, and in a woman like this where she's already been through breast cancer, she's been through radiation, she's got a cardiomyopathy with a low EF. Sure, we could do it either way. We could do a TAVR, we could do an open case, but she's at a higher risk for a wound infection because of the radiation and the mastectomy. She's at a higher risk for a protracted recovery because of the low EF. And I think on balance, we've shown safety, we've shown efficacy of TAVR in intermediate risk patients, and I think she is someone who subjectively will do better from a quality of life metric than opening her chest.
Okay, very good. Now, JK, you want to take us through
to the angio. So this patient, very interesting, had very, very high bifurcations of the external iliac into actually the profunda and the superficial femoral, so much so that on the left side there's basically no common femoral artery at all. So we've stuck into the superficial femoral on the left. This is our access point for the big sheath. We knew this was a very high bifurcation on the right. We've already put a wire, crossover wire up and over. That's an 018 wire, and we're just checking if we're high enough here. You can see here, this is a very LAO projection. Our first stick, this is just with a 1 French introducer sheath. We're actually in the superficial femoral here, so we restuck this, got higher, and you can see now I've successfully got right up into the common femoral there, and this was our access point for the big sheath. We're checking here that the valve has been properly aligned and properly seated. The paddles there are nicely flush with the CoreValve. So
at the bottom part of the valve.
Exactly, the CoreValve is loaded and ready to go. Getting our root shot here to correctly align the cusps. You can see here this is an LAO caudal projection, nicely aligned the cusps in a horizontal plane, and we can see all 3 cusps there. Here we are taking in, we've gone with a solopath sheath, so 2 pre-closed sutures have been placed in the right common femoral. The solopath went very easily. We inflate the solopath to 20 atmospheres and it takes it up to the full size of 18 French, and we're ready to go.
Good. All right, and Dr. Keeney just joined. Anup, you can comment on this now. Evolute R, particularly with the recapturable condition, the device also, that what is our experience in terms of recapture or putting a second valve in a valve so far?
Actually, the recapture, I would say the valve morphology and the way the stent is way better than their first generation. So though we are able to recapture, I can say ever since we started doing this, we have only recaptured 2 valves and 0 valve in valve since we started using the Evolute. Agree, Alan?
Yes, I agree.
And that is very important because one of my point of discussion today is the valve degeneration and thrombosis. And valve in valve has been one of the important factor in patients who present with a TAVR thrombosis as well as valve degeneration. So idea is that you are able to put a valve which you can recapture, and that's I think many of the other designs like direct flow where you have full deployment and still you can change the position is very important, and same thing will happen with the other valves which are going to come in the future. That ability to adjust just sort of full deployment.
I think where it really comes into equation when we are having these cases who have a little bit of a septal bulge. We're not talking the true, is where patients have some kind of a septal bulge, where we know where should we exactly start placing the valve, whether we are at the level of the annulus 4 millimeter down, 6 millimeter down. This is where we try to think 4 millimeter is good. If it does not, when you are, if it has moved up, you are able to recapture and go back in and place it properly. I think in that, those kind of patient population, the valve really plays a very important role.
We'll try with AL1 catheter now.
Yeah. What happened is we had the AR2. Actually, wire has gone in.
Oh,
I don't have wire.
wire?
Yeah,
I
no.
don't have it.
No.
Very good. Keep it in.
No,
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 but we don't have the
we
room.
don't have wire here.
Yeah. What happened is AR2 was not pointing properly. So now we are going with the AL.
But
Yeah. Yeah. See? So it's a clearly that.
Even when you put AL down in the groin, it went in.
Yes. Okay. So we are ready here for quick
let's
measurement.
see. Yeah, pull back.
The wire position is good.
Good. Okay. You want to go to the lateral view? Okay.
Why?
We can
No,
show the
it's good.
gradient. Now you do valvuloplasty. I do the valvuloplasty here.
So can we see the gradient here on the screen,
Okay.
please, the hemodynamic? Can we see the hemodynamics on the screen?
Soft wire.
Catheter.
Soft
You want to
wire.
reposition the
wire.
virus.
Okay.
I mean,
Yeah,
the
as you
catheter.
can see that although gradient is there,
Yeah,
40
gradient
plus,
is about 40,
but
yeah.
the catheter is not pointing well. So
Yeah.
clearly we learned that this step is very important, that you take
Okay, very good. Let's
your
go back
wire,
to angio, please.
Yeah. And then position your wire into the apex. You know, it's such a small thing, but we learned that this is what can create a problem.
Flushed.
It's a very dilated ventricle. Good.
Yeah, the pigtail will help a lot.
Yeah. Now we have to change. We can just go with this, right?
Okay, I'll leave it
Yeah,
there.
yeah.
No, wait,
Huh?
wait.
I think pigtail will
Yeah.
be better.
Good.
Oh,
That's
yeah,
good.
yeah,
That
yeah.
was sticking in the
Yeah.
valve. Okay.
Well, it kind of became like a pigtail, this one, so it's good. Definitely at the true
Modify
apex.
AL1 into pigtail.
Yeah. You see how eccentric the entry to the LV is. That's exactly where the initial wire
No, no,
crossed.
so this side, that
Uh,
side.
anyhow,
You and Ellen will deploy. I'll just
Compress
after
them.
dilate here. So now we have balloon
Let go, let
which
go.
There's a 20.
20
What?
millimeter balloon.
20 millimeters image.
Why is he moving?
Amen. Good.
Let me have the floor.
Now we need a little extra sedation.
Sedation, please. Hold the wire, hold the wire.
Yep.
all right, so typically perform the BAV in the RAO projection so
Yeah.
we can have a better understanding and control of the
Go.
level of the valve, and you can
Start
see that
pacing
here.
at 120. Blood pressure is okay.
Yeah.
We have to sedate the patient a little bit, he's waking up. Yeah, good. Okay, go with the syringe. Cine. What happened?
Done.
Cine.
Cine, done.
Stop pacing.
Good. Okay, bring the
Okay.
valve in. Patient is hemodynamically okay.
While they are
Yes.
Can they see the echo all the time there?
Yeah, so why don't we show the echo on one side? Yes. PIP.
Very good. So we
Okay,
have
good.
the long
We
axis
don't
of
need
the
to-
aorta now, and we're going to see how the valve
don't
is
need
going to
to
cross and position across the aortic valve in the echo at the top left and in the angio live in the right side. And the angio is going to transform now to the LAO caudal, or mainly caudal, I would say, projection as identified by the aortogram before the procedure. So aortic,
Okay.
the valve crossed very nicely. When I pull back and then unentangle the pigtail
yeah.
that we use,
Just
and
watch
then
the
advance it back
anesthetic,
into
just
the
watch the IR.
right
Hand.
coronary sinus. If we can, is always a little competition of real estate there.
it.
Yeah, it's right
It's
there.
okay.
And
Yep.
I think we're You need to make the ring a perfect
nice.
line, so you need to
Okay.
come a little bit more caudal or something.
It's really caudal already.
Yep.
Don't go too caudal. We won't be able to see.
You won't be able to see anything.
Maybe a little
Okay.
bit less LAO then.
Cine. Okay, looks good. Keep going. Keep releasing.
Okay.
Who has the pacer? Good. Not yet. Not yet. Okay. Yeah. Anchor, anchor, anchor. Yeah. Start pacing. 120. Yeah.
Okay, T probe up.
Inject.
Yeah, we can take a T probe up. Yeah.
Okay. I think
Yeah,
it's
you can
flowing.
see that we're about 3 millimeters from the left side and about
Okay. Stop pacing.
6 millimeters on the
Not
right
really.
side, but it's supposed to
Inject
readjust
again.
when we free up the valve. I think it's
I
a
think
little
it's looking
low,
good.
but
We are releasing. Okay.
Yep.
yeah, and you see it readjusted, and although
Wire.
it was on the lower side in the right side, now it is adjusted and it is about 4 millimeters on each side. It always realigns right after you release it.
All right. How is it looking on echo?
Echo looks great. The
Oh, we're
shoulders,
gonna get a short axis.
short axis now.
Go to the regular LAO view.
I don't think we see any AI.
Yeah, we don't see hardly any AI, just a tickle of AI.
Yeah, just minimal around the wire. I think we're good.
Yeah.
Let's try to put a pigtail and get the hemodynamic result.
Or do a
Go to the
aortogram
bump.
first or no?
Touch a bit on
Usually
this
we
side.
don't. If they
Okay.
looks good, we
Okay.
can get a
If
gradient.
looks good, the gradient.
Yeah.
You have-
Dr. Chaudhary, you don't need a post, right? Looks okay.
Looks good, yeah.
You're inside.
Yeah.
Just minimal AI stuff.
I have this.
Okay, so right now we're waiting for the
Hemodynamics,
wire
yeah.
to be exchanged for a pigtail in the LV.
Yep.
So we're going to have the second pressure. The blue pressure is going to be the LV. You see, actually, it's a yellow pressure. It's going to be in the LV, and the red pressure is in the aorta. That needs to be flushed a little bit.
You flush this.
Okay, and after proper flushing, you see that there is no gradient in systolic. The diastolic pressure is about 65.
Yep, that's
The
the result before.
EDP is about 20.
Good.
So it's a very successful procedure from hemodynamic point of view. We saw the echo, no AI. Let's go back to the angio, please, so we can see the final aortogram.
Good. Right there.
RAL?
Yeah.
RAL?
No, this is good.
Very well.
Good. Okay.
Okay.
Ready?
Ready for the aortogram?
Yep.
Inject.
Good. So just a 1
Plus.
plus, which is allowed, which is part of the or part of partial of the equation.
And where
Yeah.
diastolic pressure is about
60.
No, 70.
70.
70, right? Yeah.
Yeah. So from procedure point of view, we are completing. There is nothing else need to be done. We have taken the pigtail out of the ventricle.
Can the echo team show us a little bit of the echo in the big screen, please, so we can appreciate
While
the
you start
echo,
doing your thing.
long and short axis, without any equipment through the valve.
Yep.
No AI by the echo.
Yeah, right now we can remove the echo. We don't need the fluoro because we have
Yeah.
seen the last picture. Let's
Exactly.
just keep showing some echo and some fancy views
No
of the
AI
echo.
by the echo.
So this is the short axis of the echo. We don't see any aortic regurgitation, and we'll move on to the long axis. And again, we don't see any regurgitation. And we don't see any flow across the annulus or anything, so it looks good.
I mean, it just tells you that how simple these procedures have become, and with the advances in technology, getting to the 14 French, and if not for the pacemaker, many of these patients will be discharged within 36 to 48 hours, and so. So now come back to our slides presentation. So one of the topic I always try to give the latest data on what is going on at present in this field. Next slide. And of course, we have used our Evolute R system, which is we have shown the practical as well as theoretical that how recapturable if required. Next. And so basically the the point I'm going to talk about is, next slide, that is the TAVR valve thrombosis, valve degeneration, and reduced leaflet motion, because in last 1 year, we accumulated lots and lots of data about, while in the randomized trial, we had data up to 5 years now of the core, of the partner trial, as well as in the CoreValve, data up to 3 to 4+ years, that there is no valve degeneration. But clearly those are the selected cases. But what about in the general setting, in the overall widespread use of the device, where we are? Next. Now one is, we know, one thing which we need to be sure, that there is always a degeneration of the bioprosthetic valve. And this is actually the data from Mount Sinai, published in JAMA 2 years ago, in terms of comparing the bioprosthetic versus mechanical aortic valve replacement in patients with 50 to 69 years of age. Next. And you basically see that at 15 years, about 45%, whether which group you are, have a survival, is identical, which is what we learned, that maybe younger age could be different. Of course, elderly age, we don't use the mechanical valve. So in this the age group, 50 to 70, the overall survival is identical. Next, except there are some advantage and disadvantage of one versus other. That is, the stroke rate was identical, but reoperation with the bioprosthetic valve is much higher compared to mechanical, and that is the key. So, and of course, the valve degeneration and some of the patients who have died may be part of it. So clearly, we learned that in 15 years, about 40 to 50% of patients, even with the surgical bioprosthetic valve, will have a death or reoperation. And of course, the major bleeding is much higher with the mechanical. So therefore, next, so conclusion was that on the 15-year follow-up, basically you have to trade off. And therefore, by every means, you can recommend now that bioprosthetic valve should be the preferred approach, because you don't have any differences, you don't need to take anticoagulation, and there is lower bleeding. And of course, we know when your bioprosthetic valve degenerate, you can always now do the TAVR in these patients. Next. So then come back to this issue, the two issues which we are coming up for the TAVR valve. One is the valve thrombosis. So there is a big multi-center registry of 1400+ patients, and you can see that the TAVR, the thrombosis rate is about 0.61%. So 0.6% develop the thrombus and thrombosis. Next. And this actually in all the valves, and these are Dr. Marchina, who will be here 2 days later in our symposium, have presented the 4 cases, next, of the thrombosis of these valves. And many of them, they present, of course, pathologically, but otherwise also by increasing the gradient and the symptoms. Next. And clearly they have seen that there is a thrombus formation on the valve. At autopsy, of the 4, 3 died, and one of them actually improved because they diagnosed beforehand. Next. And that is by giving warfarin, and that's a very important. Once you see the thrombus, what we learned, same with the bioprosthetic, that TAVR prosthetic valve, also TAVR valve, that warfarin will decrease the gradient, as shown in this one particular case, who did not have the bad outcome. Next. So then second issue comes, that what is this valve hemodynamic deterioration? One was the thrombosis, which is very rare, but then this is the whole phenomena of the leaflet thrombosis and the valve, TAVR valve hemodynamic deterioration, with the recent very careful analysis by the echocardiography, and so has been presented with the multi-center registry. Next. And this basically, that it was defined as more than 10 millimeter gradient in the transprosthetic from the baseline. So baseline was 5, so if follow-up became 15, that is your call as a valve hemodynamic deterioration. And the mean gradient increase in the overall group of this 1500 patient was 0.3 plus minus 5 millimeter of mercury per year. So very low. Remember in the past, we have the native valve degeneration or aortic stenosis progression, we say that it's about a decrease of 1 centimeter and then gradient of about 10 millimeter per year. With the prosthetic valve, because this is still early, that we have only 0.3 overall. But if you take that, more than 10 millimeter occurs in about 4.5% of cases. So that's a good understanding that about 4.5% of patients have this valve hemodynamic deterioration. Question is, who are those? Because overall it's 0.3 only. Next. And that basically shows that this is our area of particular follow-up, that yes, valve gradient increases, and of course there will be a corresponding reduction in valve area. Now reminded, we have shown in our earlier structural heart symposium here, that 5-year follow-up of the partner 2 trial, there has been a no decrease in the gradient. But this is in the trial, but overall there is clearly the slight increase in gradient, albeit a small one, but does happen after the TAVR placement. Next. Good. So now this is what they did is they divided the patients who had the VHD, valve hemodynamic deterioration, versus no VHD. So this is the overall process starts around 3 to 4 years. But clearly that those who have it, their gradient increases. And who are those patients? One is those who are not on anticoagulation, valve in valve, less than 23 millimeter transcatheter valve, and greater body BMI. So all these patients are more predisposed for the valve hemodynamic deterioration. Next. And these are the individual odd ratio for each of these endpoints. Next. And basically these are basically showing that anticoagulation, no anticoagulation is the one to me is really coming up, sticking out, which can be modified, and that is that patients who are anticoagulation have a less valve hemodynamic deterioration, signifying that it's probably the thrombus formation on the valve which is causing this deterioration of the valve. It's not all of them are on dual antiplatelet therapy, at least for 6 months, and then of course the aspirin for lifelong. Next. So therefore they concluded that there was a mild but significant increase in the transvalvular gradient over time after TAVR, the lack of anticoagulation therapy, valve in valve, greater BMI, and use of 23 millimeter valve associated with higher VHD post-TAVR. And of course this need to be subsequently studied, and particularly with the anti-thrombotic therapy post-TAVR. And this, as you know, at present there are few trials ongoing. One of them is Galileo, which is comparing rivaroxaban in these patients who are non-AFib TAVR, they're randomizing them to aspirin plus rivaroxaban versus continue your dual antiplatelet therapy, and really will give us idea that where we are in this field. Next. And what really came up is very important is by Raj Makkar, the possible subclinical leaflet thrombosis in a bioprosthetic aortic valve, which really raised a lot of flags with the FDA also late last year. Next. And basically what they show that on the top white is your regular 2D, and of course the color is the 4D volume rendered CT. And what basically showed that if you have a reduced leaflet motion, it will look like the shadow during both systole and diastole. So like in the portico area and so on and so forth. In this study there was no reduced valve leaflet motion in the CoreValve group, but was all present in the portico sapien as well as in the surgical Carpentier Edwards. So basically that 4D CT was very specific to diagnose this reduced leaflet motion. You say, okay, what does it matter? Next. And I was basically sure that once you have reduced leaflet motion, which is on the right side compared to normal leaflet motion, that event occurs in the reduced leaflet motion group, and that is predominantly the stroke. You can see there in 3 out of 17 or 2 out of 22 in various trials, very high incidence of reduced leaflet motion associated with the stroke. Other event rate was not that different. Next. Now therefore is a 0.87 versus 17.6 with a reduced leaflet motion versus normal leaflet motion. Next. And what also is very important, they found that patients who are on anticoagulation, 0 of the 13 had a reduced leaflet motion compared to no anticoagulation was 30%. This, not only that, further observation was, next slide, and that is that if your change to the anticoagulation, your reduced leaflet motion from 21 patients, in 11 improved, compared to if you did not change it to anticoagulation, only 1 patient improved on the DAPT. So the 90% continue to be persistent leaflet motion compared to decrease in half if you change them to anti-thrombotic therapy. So clearly, I think the anti-thrombotic therapy is taking a center stage of the TAVR procedure, particularly in the reduction of this gradient, this thrombus, and the leaflet issues. Next. So this is basically the reduced aortic valve leaflet motion was shown in patients with bioprosthetic aortic valve. The condition resolved with therapeutic anticoagulation. The effect of this finding on clinical outcomes, including stroke, needs further investigation. Next. And this led to the FDA notification about the bioprosthetic aortic valve reduced leaflet motion. Next. And they basically made it is that perspective, knowing that this is a new phenomena, we don't know the long-term effect of it, so they are very clear in the FDA perspective, that FDA believes that bioprosthetic aortic valve remains reasonably safe and effective when used according to their approved indication. This view is supported by favorable benefit and risk profile observed in SAVR devices. In 30 years, they have been in the market. And in TAVR cases, in the 8 years, they have been in use. Implantation of these devices reduces symptoms, improves quality of life, and prolongs life for tens of thousands of patients each year. For patients who have a bioprosthetic aortic valve, additional diagnostic imaging using 3D or 4D CT or TE may be considered when clinically indicated. If reduced leaflet motion is found, treatment options should be discussed with the team of heart physician responsible for the patient care. So basically they're saying that yes, you don't have to do routinely, but clearly that if you have some change in gradient, I think doing a 3D 4D CT will be important. And if you see a reduced leaflet motion, probably think about giving anticoagulation if there is no contraindication. Next. And this is put in the summary. So therefore, they actually endorsed that you continue to do the TAVR valve, but we are going to monitor it. And this is what has been happening, that in the newer trials of the low risk trial, both of the SAPIEN as well as for the CoreValve, Evolute R, they actually have mandated the sub-study of the CT. So the patient will be followed and try to see prospectively what is the incidence of this bioprosthetic reduced leaflet motion in the randomized patients. Next, to sum it up now, observational studies using 4D CT and TE have shown reduced leaflet motion and thickening, likely representing early valve thrombosis. Patients with reduced leaflet motion develop transaortic gradient and is associated with higher stroke and TIA rates. This phenomenon is important, especially once TAVR being used in young and low risk cases, and CT follow-up is a part of the low risk TAVR randomized clinical trials now. Next, and this issue of TAVR leaflet thrombosis and reduced mobility is likely mediated by subclinical thrombus on the leaflet, and process can be reversed by long-term therapeutic anticoagulation, but not by DAPT only, and we have seen those data. Again, there is nothing prospective, they're all observational. But randomized clinical trials are being done to evaluate role of oral anticoagulation in TAVR patients, and usually they are using the NOAC and not the warfarin, because where we have the most data in the observation. With that note, and actually just coming back to the questions, and then we'll ask JK to give us the final on the angiograph, the closure. This is the incidence of TAVR valve thrombosis in multi-center registry is less than 1, 1 to 2, 2 to 5, and more than 5. Second question. The following statements are true about the TAVR valve degeneration, except that it is usually asymptomatic. It is associated with reduced leaflet motion on TE or CT. It is a benign condition and is not associated with any MACE. It is associated with increase in transprosthetic gradient. And third question, is the following statement correctly describe the phenomena of TAVR valve thrombosis and reduced leaflet motion? It is a common occurrence post-TAVR. Patients are usually symptomatic. T is better than volume rendered 4D CT. In diagnosis, it occurs less in patients on long-term therapeutic anticoagulation. Next. So question is, we learned in the registry, the TAVR valve thrombosis was 0.61. Next, the answer is A. Next question, the TAVR valve degeneration. Next, and in this case, clearly that it's a benign condition, is not associated with any MACE, is wrong. Last question answer. Third one is that describe this phenomena that it occurs less in patients on long-term therapeutic anticoagulation. So with that note, JK, Dr. Kovacic,
Sure.
can just tell us about the closure issues.
Sure. Please show the cine angios, please.
Yeah.
That's it. So this is our last, where we left off. So the first step that we've done here in closure is we've pulled back the 18 French sheath into the right common iliac. We've put in a long sheath into the left femoral, and we've advanced that up into the mid common iliac on the left. We're doing a DSA just to check the aortic bifurcation, no problems, and you can see this is looking good. We then actually advance our sheath from the left side up and over. We've crossed over now. We now have that sheath in the top of the the right common iliac. We've further pulled back the 18 French sheath just an inch or so above where our access point is, and we're checking that we've got no problems in that going through that mid-iliac artery, and obviously no problems there. The next thing we've done is we've removed the 18 French sheath. I've deployed the 2 perclosed sutures, and now we're taking another angio with the sheath out. At this point, you can see there is a little 50%, 40% stenosis where the sheath entered into the vessel. We have both an antegrade and a retrograde wire at this stage, so we have great control. But with this mild little stenosis, what we did is we pulled out the retrograde wire, so pulled out the wire the sheath was on, and advanced a small balloon. This is a 7040 balloon across to where we actually access the vessel. 4 atmosphere inflation for 30 seconds with a 7040. You can see here we've now dealt with that little mild stenosis, looking good. We're injecting around the balloon here, so that's not a very good shot. Here's our final completion shot. You can see here great hemostasis, the waste is gone, that little stenosis is gone, and the case is finished.
Great. Jason, can you go back to the final view of the valve? We have an interesting question coming from Japan asking us, how do we select the valve implantation projection? Because they saw very nicely, we place a wire in the LAO and then went to RAO to make sure the wire is in the apex. We advanced a pigtail, perhaps yes or no. They all understood all that. But there's a little confusion, how come we changed to an LAO projection? And the questioning is, does this have to do with the coronary ostia and all that?
Right.
The answer is it doesn't have anything to do with the coronary ostia. It has to do with the alignment of the valve with the annulus. Can you talk a little bit more how we selected this view? The 620 in this patient to begin with, and then we refined it and became, I think, 25, 29.
Sure. So this is obviously, as we're getting set up for the case, we've taken this view to actually align the annular plane, so you can see the basal points of the 3 cusps of the valve apparatus are all in a line. So we actually have the pigtail in the non-coronary cusp here, but you can see there's a straight horizontal line across those 3, and they're symmetric in their alignment. So this is 6 LAO caudal 20. Then what we do is we actually start in that position. I'll just get you to where we actually deployed the valve. We start in that position, but back.
You had your no.
This is where I actually decided to deploy. And you actually see we're more LAO, we're LAO 20 and we're caudal 32. What we're aligning on here is that circular ring, which is just there right at the bottom of the CoreValve, about 1 centimetre up from the very bottom of the CoreValve, close to where the pigtail is. We've actually just squared off on that ring, almost squared off on that ring. Normally we just do that by adjusting AP and caudal, but in this case we're already very caudal, and you can sneak a little more alignment of that ring by going just a touch LAO as we did. So we've actually got side onto the valve here for the final deployment view, and that's how we set ourselves up.
And
I think one point, GD, maybe you can tell them, the key is that the oval shape that you normally see at the distal end of the ring should look like a straight line. And until it looks like a straight line, though you take an aogram, doesn't matter which view your aogram is, you still will move around.
Right above the very distal tip of the valve, there's a little bit of a ring. That if you're not aligned,
should not be oval.
We're not aligned well with your projection with the ring. This means you may have a lot of parallax error in where you think the valve is and where it really is. And the definition of how we select this view is exactly this one. We have to select it so it's aligned with the annulus. So we have eliminate as much as possible the parallax error in thinking where the valve is going to end and where it will actually end. This has nothing to do with coronary ostia with any other structure. We're only focused on the annulus of the valve and to make sure the prosthetic valve is aligned as well as possible with our projection.
They have to understand what we are seeing right now here
and
is
show
a 2D,
the final valve, please, so they can appreciate that the valve landed 100% aligned. 100% aligned in the end, because you see just a straight line in the top or at the bottom of the valve. You don't see any oval much. So the valve is exactly aligned very nicely with our projection. Very good question.
I was just, GD, other question that we needed to tell them is this is what, when we are doing aogram and we are placing the valve, it's just a 2D view we are seeing, but we don't know the 3D part where the valve is going to end. And that is why it's very important that before you start releasing the valve, that the ring, which is oval shaped, has to be a straight line, making sure the posterior part or the non-coronary part, that the one that we are not seeing, the valve will be still at the level of the annulus or below the annulus and not move up. In
That's
certain,
correct.
Yeah.
And
in
CoreValve only has this ring
Yeah.
assessment, which makes it sort of easy, I would say, to see
Okay.
that.
All right. With that note, we are done from our side.
Okay, I'd like to thank the Dr. Sharma, Dr. Kinney, Dr. Stewart, Dr. Khan, and the anesthesiologist, Dr. Chowdhury, all the nurses and techs, and say goodbye to the cath labs. And
Yes.
then we go to our announcements. We have a lot of things to talk about. Number one, next structural website here in the same time, anywhere you may be around the world, August 9. Again, Tuesday, August 9. If you have any questions about this webcast, we will continue answering the other blog, and email us please at info@structuralheartlivecases.org. You can see this case as well as any previous case we've done at the archive part of this website. And let me talk a little bit about our symposium that starts live actually from today. We have a function for the endovascular fellows course today at the Convene Center, and you can see this as well as the entire program at cccsymposium.org. The 3 C's in the beginning, cccsymposium.org. Tomorrow is a Wednesday, June 15. We're going to have the endovascular symposium event here at Mount Sinai Main Medical Center in New York. And there will be an evening symposium for the coronary program later in the evening tomorrow, Wednesday evening. And that will be at the Sheraton, New York. And there will be the coronary and structural heart symposium here at Mount Sinai on Thursday, June 16th. And on Friday, June 17th, we will have the coronary and structural fellows course here, or board review course, I should say, here at Mount Sinai. So this will be the various activities starting from tonight, and the vascular fellows program, dinner, and we have tomorrow tomorrow a whole day the endovascular course. Then on Thursday we have the coronary and structural heart disease course, and Friday we have the board review course for the coronary and structural fellows. I think at this point I'd like to conclude the webcast, and thank you for your attention.